Intermittent Explosive Disorder, IED, represents one of the most disruptive impulse control disorders, characterized by recurrent episodes of impulsive, aggressive, and violent behavior that are grossly disproportionate to the situation. These episodes manifest as verbal aggression, property destruction, or physical assaults, occurring with minimal or no provocation. The hallmark of this disorder is the individual's inability to resist aggressive impulses, with outbursts typically lasting less than 30 minutes before the person returns to their baseline state. What distinguishes IED from normal anger responses is the profound intensity, rapid escalation, and the marked disconnect between the triggering situation and the resulting explosive reaction. Between episodes, individuals with IED often appear perfectly composed, which creates a jarring contrast with their explosive states and frequently confuses those around them. Research indicates that IED affects approximately 5 to 7% of the general population during their lifetime, with males showing slightly higher prevalence rates than females. The disorder typically emerges during adolescence, with an average onset age between 13 and 15 years, though symptoms can appear earlier in childhood or later in life. This early onset makes IED particularly disruptive to educational achievement, career development, and the formation of healthy relationships during critical developmental periods. The condition rarely develops after age 40, suggesting that certain developmental vulnerabilities play a significant role in its etiology. Importantly, diagnosis requires that the aggressive episodes cannot be better explained by other mental disorders, medical conditions, or substance use, making proper assessment crucial. The neurobiological underpinnings of IED involve significant abnormalities in the brain's aggression regulation systems. Neuroimaging studies reveal structural and functional alterations in the prefrontal cortex, particularly the orbitofrontal and anterior cingulate regions, which normally serve to inhibit aggressive impulses. Additionally, hyperreactivity in the amygdala, the brain's threat detection center, contributes to exaggerated responses to perceived provocations. These brain abnormalities manifest in dysregulated serotonergic activity, with reduced serotonin function consistently associated with impulsive aggression. Lower levels of the serotonin metabolite 5-HIAA have been found in the cerebrospinal fluid of individuals with IED, supporting the critical role of serotonin dysregulation in the disorder's neurochemistry. Genetic factors substantially contribute to IED vulnerability, with studies showing 44 to 72% heritability rates. First-degree relatives of individuals with IED show higher rates of both the disorder itself and related conditions involving impulsivity and aggression. Specific candidate genes associated with serotonin regulation, including the tryptophan hydroxylase 2 gene and serotonin transporter gene, have been implicated through genetic studies. However, environmental factors play an equally important role in triggering and shaping the expression of these genetic vulnerabilities. Early childhood experiences, particularly exposure to violence, childhood maltreatment, harsh parenting, and inconsistent discipline, significantly increase the risk of developing IED. These adverse childhood experiences appear to alter brain development during critical periods, affecting the neural circuitry involved in emotional regulation and impulse control. The diagnostic criteria for IED according to the DSM-5 require recurrent behavioral outbursts representing a failure to control aggressive impulses, with the severity of aggression expressed being grossly out of proportion to the provocation or precipitating psychosocial stressors. For diagnosis, an individual must exhibit either verbal aggression or physical aggression toward property, animals, or other individuals, occurring twice weekly for 3 months, though not resulting in physical damage or injury, or 3 behavioral outbursts involving damage or destruction of property or physical assault with injury over a 12-month period. Critically, these aggressive episodes must not be premeditated or committed to achieve some tangible objective, and must cause marked distress, impaired occupational or interpersonal functioning, or legal/financial consequences. The assessment process for IED involves comprehensive clinical interviews, standardized anger assessments, behavioral observations, and collateral information from family members or close associates. Clinicians must carefully differentiate IED from other conditions with similar presentations, including bipolar disorder, borderline personality disorder, conduct disorder, antisocial personality disorder, and substance-induced aggression. Medical evaluations are essential to rule out neurological conditions such as temporal lobe epilepsy, brain tumors, or traumatic brain injuries that can manifest with similar explosive behavior. Laboratory tests may be conducted to exclude endocrine disturbances or substance use that could account for aggressive episodes. This thorough differential diagnostic process ensures appropriate treatment planning and intervention approaches. Cognitive behavioral therapy, CBT, represents the most evidence-supported psychotherapeutic approach for treating IED. CBT interventions focus on helping individuals identify the early warning signs of building anger, recognize cognitive distortions that fuel aggression, develop effective coping strategies, implement relaxation techniques, and learn problem-solving skills to navigate triggering situations constructively. Specific anger management techniques include stress inoculation training, which gradually exposes individuals to increasingly provocative situations while practicing control strategies, cognitive restructuring, which addresses hostile attribution bias and other distorted thinking patterns, and communication skills training to express needs and frustrations appropriately. These techniques enable individuals to interrupt the rapid escalation from trigger to explosion that characterizes IED episodes. Pharmacological treatment for IED primarily targets the neurobiological abnormalities underlying the disorder. Selective serotonin reuptake inhibitors, SSRIs, like fluoxetine and sertraline, have demonstrated efficacy in reducing aggressive outbursts by enhancing serotonergic functioning. Mood stabilizers, particularly carbamazepine, divalproex sodium, and lithium, help modulate the neural circuitry involved in emotion regulation and impulse control. For some individuals, particularly those with comorbid ADHD symptoms, stimulant medications may reduce impulsivity and improve frustration tolerance. Atypical antipsychotics like risperidone and quetiapine are sometimes used as adjunctive treatments for severe, treatment-resistant cases. The optimal pharmacological approach often involves careful medication trials and adjustments, frequently in combination with psychotherapy for maximum effectiveness. The impact of IED extends far beyond the affected individual, creating profound ripple effects throughout their social ecosystem. Intimate relationships suffer tremendously, with partners experiencing fear, walking on eggshells, and eventual emotional detachment. Children growing up with a parent who has untreated IED often develop anxiety, traumatic stress symptoms, and may model the same explosive behavior patterns. Workplace functioning is frequently compromised, with individuals facing disciplinary actions, job loss, and difficulty maintaining stable employment due to conflict with colleagues or customers. Legal consequences commonly include assault charges, destruction of property citations, domestic violence arrests, and restraining orders. These multifaceted consequences underscore why early intervention is so critical for breaking the cycle of explosive behavior and its devastating aftermath. Living with or supporting someone with IED requires specific strategies for safety planning and crisis management. Family members benefit from learning to recognize early warning signs of building tension and implementing de-escalation techniques that avoid confrontation during heightened states. Establishing clear boundaries around acceptable behavior while expressing empathy for the individual's struggle to control impulses creates a balanced approach. Support groups for family members provide validation, reduce isolation, and offer practical coping strategies from others with similar experiences. Educational resources about the neurobiological basis of the disorder can help loved ones understand that these behaviors stem from genuine neurological differences rather than deliberate choices, fostering compassion while still maintaining appropriate boundaries. The prognosis for IED varies based on several factors, including age of onset, treatment adherence, comorbidities, and support systems. Early intervention significantly improves outcomes, particularly when treatment begins in adolescence before behavioral patterns become deeply entrenched. While complete remission is possible for some individuals, many experience a chronic course requiring ongoing management rather than a definitive cure. With appropriate treatment, most individuals achieve substantial reduction in frequency, intensity, and duration of explosive episodes, allowing for improved functioning across life domains. Long-term studies indicate that approximately 40 to 60% of individuals show significant improvement with comprehensive treatment approaches combining medication and psychotherapy, though relapse prevention strategies remain essential throughout the lifespan. Despite these challenges, greater awareness, improved diagnostic practices, and advancing treatment modalities continue to improve outcomes for those affected by this challenging disorder.